I'm Samantha. I'm going to be your nurse practitioner today. What brings you in?
I'm here for my annual exam.
Okay, great. I'm going to start by doing an assessment. A neuro assessment, a cardiac respiratory assessment, and an abdominal assessment. Is that okay?
Okay.
All right. So I'm going to start off by testing your orientation status. Can you tell me your name and date of birth?
Morgan Costa, June 26, 1992.
Good. And what's today's date?
April 5th, 2018.
And do you know who the president is?
Donald Trump.
Great. So next we're going to move on to the cranial nerves. You've already gotten your eye exam, 20/20 vision, so we'll skip the Snellen test and move right on to test your pupil reactions. So if you'll just look straight at my nose. Okay, good. And then follow my finger with just your eyes. All right, good. Now it's testing your extraocular movements. Now I'm just going to have you smile, puff out your cheeks, raise your eyebrows, stick out your tongue, and move it side to side. And then I would typically assess her gag reflex. Next, I'm going to test your facial sensations. You're going to tell me whether you feel a soft, a sharp, or a dull feeling with your eyes closed.
Okay.
Okay? And what do you feel?
Soft.
Good.
Soft.
Good.
Dull. Dull. Sharp. Sharp.
Good. Now I'm going to test your neck strength, so just shrug your shoulders for me against my hands. Good. Squeeze my fingers. Good, and just lay back a little bit for me. And push down on my hands and up. Good. With your eyes closed, bring your fingers to your nose. Good, and then bring your heel to your knee and slide it down your shin with both legs. Good, stand up for me. I'm just going to test your gait. Just walk normally. Good. And then face me with your eyes closed and your palms facing up. I'm going to test your pronator drift. Good, you can sit down. And the same way we did your face, the sensation, we're going to do your arms and legs. So you'll tell me if you feel soft, dull, or sharp. And close your eyes. We'll start with your arms.
Soft. Soft. Dull. Dull. Sharp. Sharp. Soft. Soft. Dull. Dull. Sharp. Sharp.
Good. And then last, I'm gonna put two different objects in your hand, and I just need you to tell me what they are with your eyes closed.
Paperclip.
Good. And your other hand?
Coin.
Good. And that concludes your neuro exam. Next, we're going to switch to cardiac and respiratory. We've already got a set of vitals earlier today. Have you been experiencing any shortness of breath, chest pain, or palpitations?
No.
Do you smoke socially?
No.
Or anytime?
Not socially.
Sorry.
No.
So I'm going to inspect the shape of your chest. I'm going to look for symmetry and make sure everything's normal. Great. And typically I would have her exposed properly. Next, I'm going to palpate for proper expansion of your chest. So take a deep breath. Good. While I'm here, I'm going to palpate for tactile fremitus. So every time I move my hands, just repeat 99.
99. 99. 99. 99. 99.
Good. Next, we're going to percuss, and I want resonant sound. And then to the back. Now I'm going to auscultate for clear sounds, no adventitious. Just breathe normally. Next, I'm going to auscultate for bronchophony. So every time I move my stethoscope, again, you're going to say 99.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Good. We're going to switch over to the cardiovascular. We've already done the inspection and checked for symmetry. I'm going to inspect your hands and your feet, looking for capillary refill less than 3 seconds and edema. I'm going to palpate your carotid arteries. And now I'm going to palpate for the point of maximum PMI. So lay back for me. Mid-clavicular, 5th intercostal space, so I'll count down. And then turn on your left side for me. Good, you can sit up and I'm going to check your pulses. Radial and brachial on both sides. Lay back to femoral. And you can sit back up, sorry. Do popliteal. And the PT and the DP. Next, we're going to listen to all the sounds. We're going to listen to your carotid arteries first. Okay, I'm going to have you lie down to listen to your heart sounds. And then I'm going to listen to the abdominal aorta. The renal arteries. Iliac. And femoral. No bruise found in any. We would obtain an EKG if needed, but everything looks normal for you. That's the end of our cardiac and respiratory assessment. Okay, last we're going to do the abdominal assessment. Have you been experiencing any belly pain or tenderness?
No.
Nausea, vomiting, diarrhea?
No.
When was your last bowel movement?
This morning.
Okay, great. I'm going to have you lay down. And just pull up your shirt for me. Make sure the patient's properly exposed. I'm going to inspect the abdomen. It's flat, symmetric, no abnormal findings or masses. Next, I'm going to auscultate all 4 quadrants, listening for bowel sounds. All bowel sounds are normal active. Next, I'm going to percuss on your belly. All abdominal sounds should be generally tympanic. I'm going to percuss the spleen, which should be dull. And then for the liver span. And then I'm going to palpate just lightly. Let me know if there's any pain and I'll stop. Okay, I'm going to palpate for the liver. And then palpate for the spleen, which should not be palpable. Next, I'm just going to push a little bit harder, and I'm looking for masses or any abnormal findings. Again, if there's pain, you just let me know. And then I'm going to palpate for the kidneys, which should also not be palpable. If you'll sit up for me, I'm going to, just stay like that. I'm going to check for CVA tenderness. And there should be no reaction from the patient. That's it. The last part of the assessment is going to be done with me talking because the assessment pieces can be a little bit uncomfortable for people. I'm going to do the male genitalia and a rectal exam. So with the male genitalia, you want to begin by gaining a health history prior to examination. And you want to make sure that the patient feels comfortable because this can be a sensitive area. Be sure to explain to the patient what you're going to do, what they can expect during the exam so that they can feel as comfortable as possible. You're going to begin by gowning the patient appropriately and exposing only the genitalia and the inguinal areas. Gloves should be worn throughout the whole exam. First is inspection. Inspect the penis starting with the skin. Inspect both the ventral and dorsal surfaces and the base of the penis for excoriations or inflammation. Pubic or genital excoriations suggest lice or scabies. Next, inspect the foreskin. If present, retract or ask the patient to retract the foreskin. This step is essential for detection of cankers or carcinomas. Smegma, which is a cheesy whitish material, frequently accumulates under the foreskin, which is completely normal. Inspect the glands. Look for any ulcers, scars, nodules, or inflammation. Inspect the location of the urethral meatus. Hypospadias is a congenital ventral displacement of the meatus on the penis. Compress the glands gently between your index finger above and your thumb below and note any discharge. Normally, there is none. If discharge is noted, have a glass slide and culture materials ready. Next, you're going to palpate the shaft of the penis between your thumb and first two fingers, noting any indurations or abnormalities, including tenderness. If you retracted the foreskin during this portion of the exam, replace it before proceeding onto the scrotum. Induration along the ventral surface of the penis suggests a urethral stricture or carcinoma, and tenderness suggests periurethral inflammation from a urethral stricture. Moving on to the scrotum, inspect the skin by lifting up the scrotum so that you can inspect the posterior surface. Note any lesions or scars. Also note the pubic hair distribution. Inspection may reveal scrotal nevi, hemangiomas, as well as STIs, including condyloma or ulcers from herpes. Next, inspect the scrotal contours for any swelling, lumps, veins, bulging masses, or asymmetry of the left and right hemiscrotum. A poorly developed scrotum, or on one or both, suggests cryptorchidism. Inspect the inguinal areas and note any erythema, excoriation, or visible adenopathy. Erythema and mild excoriation can point to a fungal infection, which is not uncommon in this moist of an area. Palpate each testes and epididymis between your thumb and first two fingers individually. The testes should be firm but not hard, descending, symmetric, non-tender, and without masses. Tender, painful scrotal swelling is present in acute epididymitis, acute orchitis, torsion of the spermatic cord, or strangulated inguinal hernia. For each testes, assess size, shape, consistency, and tenderness. Pressure on the testes normally produces a deep visceral pain, but any painless nodules noted on the testes raises the possibility of testicular cancer. Palpate each spermatic cord between your thumb and fingers from the epididymis to the external inguinal ring. Note any nodules or swelling. Swelling in the scrotum can be evaluated by darkening the room and shining a bright light from behind the scrotum. After the physical exam is complete, you want to educate your patient on the importance of performing a self-examination once a month. Explain to your patient that this is normal for one testicle to be slightly larger than the other and for one to possibly hang lower than the other. Moving on to the rectal exam, you want to again make sure to gain a health history prior to examination, make the patient feel comfortable because of the sensitive areas, and be sure to explain step by step what you're going to do and what they can expect. Begin by positioning the patient in a left side-lying position to allow for good visualization of the perianal and sacrococcygeal areas. Drape the patient appropriately and adjust the light to ensure good visualization. Always make sure that your hands are gloved and spread the buttocks apart. Inspect the sacrococcygeal and perianal areas for lumps, ulcers, inflammation, rashes, or excoriations. Adult perianal skin is normally more pigmented and somewhat coarser than the skin over the buttocks. Palpate any abnormal areas, noting lumps or tenderness. Examine the anus and rectum. Lubricate your gloved index finger and be sure to explain to the patient that they may feel the urge to move their bowels, but this won't occur. Ask the patient to bear down as if they're having a bowel movement and inspect the anus, noting any lesions. Next, while the patient is bearing down, place the pad of your gloved and lubricated index finger over the anus. As the sphincter relaxes, gently insert your fingertip into the anal canal in the direction pointing toward the umbilicus. If the sphincter tightens, reassure the patient, and as they relax, proceed with the exam. Do not apply force. If the patient feels severe tenderness or pain, place your fingers on both sides of the anus, gently spread the orifice, and ask the patient to bear down. If then you can proceed without discomfort, note the sphincter tone of the anus. Normally, the muscles close smoothly around your finger. Initial resting tone reflects the integrity of the internal anal sphincter. To check external sphincter tone, ask the patient to squeeze your finger with the rectal muscles. Be sure to note any tenderness, induration, irregularities, or nodules. Next, palpate the rectal surface by inserting your fingers into the rectum as far as possible. Rotate your hand clockwise to palpate as much of the rectal surface as possible on the patient's right side, then counterclockwise to palpate the surface posteriorly and on the patient's left side. Again, be sure to note any induration or irregularities. To bring a possible lesion into reach, take your finger off the rectal surface, ask the patient to bear down, and palpate again. In a male, this is when you would assess the prostate. Rotate your hand further counterclockwise so that your finger can examine the posterior surface of the prostate gland. If you turn your body slightly away from the patient, you can feel this area more easily. Be sure to inform the patient that examining the prostate gland may prompt an urge to urinate. Sweep your finger carefully over the prostate gland, identifying its lateral lobes and the groove of the median sulcus between them. Note the size, shape, mobility, and consistency of the prostate. Identify any nodules or tenderness. A normal prostate is rubbery and non-tender. If possible, extend your finger above the prostate to the region of the seminal vesicles and the peritoneal cavity and sweep the anterior wall, noting any nodules or tenderness. Gently withdraw your finger and wipe the anus, or provide tissues to the patient to do so themselves. Note the appearance of any fecal matter on your glove. This concludes the assessment.